I'd like to now invite up Pamela Singer and Elizabeth Klocko. Pam is a senior social worker who's worked at the medical center for over 20 years. She was previously with the a primary social worker for Rusk's inpatient stroke and brain injury unit, and currently works in the outpatient ambulatory care center. She's run numerous stroke support groups and has spoken extensively on the emotional impact of strokes on patients and families. And Elizabeth is a clinical specialist in the occupational therapy department at Rusk. She works in the inpatient unit and is involved in clinical mentoring and program development, and she's been working at the medical center for 8 years. So we're opening it up to questions now to any one of them, and if I don't see hands go immediately up, I will start. But please, does anyone have any questions to start us off? Yeah, Judy.
Dr. Stiller, could you define and describe a TIA, and what is the percentage of people who experience the TIA who will then experience a stroke?
So a TIA is two things. They are the exact symptoms that you would expect with a stroke. They can come on abruptly. They can be caused by exactly the same risk factors that a stroke causes. But the symptoms resolve. The symptoms resolve quickly, usually within a few minutes, usually not much longer. But there's two parts. In addition to that, when we take a scan, such as a CAT scan or MRI, there is no sign of permanent damage. In other words, those scans are normal. In the old days, we didn't have CAT scans and MRIs. We would say that the patient got better in 24 hours. But a lot of people who do get better in a few hours or a day still have had a small stroke. We just didn't see them. So technically, a TIA has to be very brief symptoms, more than a few minutes, let's say, and their imaging studies don't show any damage. Now, why is that important? That's important because those patients have a very high percentage of going on to have a stroke. And there's various analysis, but as the first 30 days, actually, there's a very high recurrence rate. It could be as much as 15 or 20% in some people, depending on how ill they are. Over the course of a year, it could be as much as 5 or 10%, let's say. So there are various statistics. What I'm trying to emphasize is they are at high risk for stroke, and the sicker they are, the more risk factors they have, the more they are likely to have another stroke. The problem with the TIA is the patient doesn't tell anybody, or they don't recognize, because they've gotten better, that it's something they need to be worried about. It's quite the opposite, as we just realized, that their chance of having a real stroke is very high. So these patients we treat with the same urgency. We don't give them the clot-busting drug because they don't need it, but we need to know why they had a stroke, and that's an opportunity to catch them before they have the larger one in the future.
So usually if someone has a TIA, you scan them to make sure?
Yes, we do exactly the same tests, because in a large amount of those patients do have a very small stroke. They got better, so it looks like a TIA, but you actually can still document that some of them have had a very small stroke show up on usually MRI scan, which is much better. So a lot of times people will have a CAT scan, but if we do an MRI on top of that, we will actually find something very small. And then even if they got better, we call that a stroke because something showed up on the scan. So that's the difference. They have to get better clinically, and the scan has to be normal to truly call it an actual TIA.
Any other questions from the audience? We put together some sort of frequently asked questions. What is the incidence of having a second stroke? Oh, obviously, having a stroke must be a risk factor. So what is the incidence of people having a second stroke?
Well, clearly that answer is complicated because it depends on what you do about it. If the person has not attended to any of the risk factors that have caused their stroke, they're in the same boat that they started off in. The opportunity to intervene now has to do with risk factors and lifestyle modification. For example, if you simply treat the hypertension, you probably can cut the risk down by maybe 25 or 30%. If you add a statin, a cholesterol drug, that can add another 40% relative decrease. So if we address all the risk factors that added up to cause that person's stroke, we can cut their stroke risk dramatically. If we find that they have a blockage in their carotid artery, we can intervene by doing surgery or stenting. If we find that they have atrial fibrillation, we can put them on an anticoagulant so that the risk is dropped dramatically. So my answer is it depends if you're able to find the cause and then do something about the risk that caused that stroke. So it is very treatable, it's very preventable, but as we heard, a lot of people leave the hospital and don't attend to their blood pressure. They don't take the medicines we prescribe for them. So it's not just what we do, it's also whether the patient's going to follow their instructions. And there's another comment.
Just if I can add on to that. So one of the things that we do in the acute inpatient rehab model is that we do education with both the patients and their family members to try to hone in on where they can make changes in their life, if it means being a little bit more active or monitoring their blood pressure at home or having the family involved in setting out the medications to make sure that they are actually taking them. And that people have been very happy with kind of that education that's provided and been very receptive to it to make those active changes.
Pam, I wonder if you can, we didn't get into detail, obviously, in the time that we had and the impact on functioning and the impact of the family involvement in post hospitalization care and what you've seen in the groups you've done, both of people who've had a stroke and survived and family members and their involvement and the impact on them.
Sure, and this is a good segue of what Elizabeth was saying in terms of both the education and the involvement of the family, because caregivers and families are the number one most important element in stroke rehabilitation ongoing, and we really can't undermine the importance of having the caregiver and family involved. And that starts, as both Dr. Siller and Dr. Rashbaum said, very early on with the acute stroke in terms of education and family involvement. So one of the things both that we do, that I did as an inpatient social worker and continue to do as an outpatient social worker, is really help educate our patients and their families at every level and try and encourage them as much as possible to be involved in support groups and hooking up. There's so much out there for caregivers and families and for our stroke patients, so that, as stroke rehabilitation goes on, and as Dr. Rashbaum said, this can be a lifelong thing for somebody who's had a stroke. It's really important to be connected in the community, and that's certainly one of the main things that we do. I run a stroke support group. There are many others that are run through the American Heart Association, the American Stroke Association. There are online groups, there are meetup groups. There's really a lot of resources out there for our patients and families. And again, we can't emphasize enough the importance of the involvement of caregivers and families as we help our patients ongoing with their stroke rehabilitation.
So one comment I would make on the idea of caregiver stress. There's a whole literature showing that caregiver stress is often a problem when it comes to taking care of that caregiver themselves, and then that impacts on how well they take care of their family members. So there's a whole new group of what we call community health workers to date that actually allow us to parlay some of that stress to somebody who's trained professionally, and they can actually help to navigate the patient both back to primary care, but also to help the patient engage in those recommended lifestyle behaviors that we often that's not stressed in the acute setting, or that they often allow people to follow up with once they're discharged to the home. There's a whole literature on that, something to think about, because in New York City, there's actually an association of community health workers, and these are trained people. We're doing studies now where we're actually training community health workers to help patients with complex comorbid conditions, because health literacy is a major problem. You can imagine somebody is discharged with stroke. They don't have the functional literacy, talk less of the health literacy. In other words, they have to deal with all these things. The health worker allows them to allay that stress and still meet up with their regular obligations.
Yeah, I'm glad you said that. I'll say Dr. O because I can't pronounce your name. That's an excellent point, and we certainly want to help our patients and families get connected to whatever resources and community home health workers and people that are, again, just going back to what the doctors said, are going to help them in the continuum of care, make sure they get the right medical attention, make sure the caregivers get the support that they need, and make sure that they get the concrete and financial and home health aid resources that they're entitled to.